Dr. Marwan Alhalabi is the immediate past president of the Middle East Fertility Society, MIFS, president of Syrian Society of OBGYN and president-elect of Federation of Arab Societies of OBGYN, FAGOS. He is professor of reproductive medicine, vice dean for scientific affairs at Faculty of Medicine of Damascus University. He is also head of Assisted Reproduction Unit and consultant medical director of Orient Hospital. Dr. Marwan Alhalabi will be talking about cesarean scar pregnancy, diagnostic and management dilemma. Dr. Marwan Alhalabi, the floor is yours.
Good morning, everyone. Firstly, I would like to thank the organizing committee for inviting me to be here in this virtual conference, hoping next year to be held in Beirut. I would like to talk about cesarean scar pregnancy, diagnostic and management dilemma. The first known description of an ectopic pregnancy is by albio cases in the 11th century. And the incidence of the cesarean scar pregnancy is less than 1%. The risk factor of cesarean scar pregnancy include cesarean delivery, earlier cesarean scar pregnancy, repeated cesarean scar pregnancies, earlier surgery, and brief interval between the surgery and subsequent conception. Cesarean scar pregnancy is an ectopic pregnancy implanted in the myometrium at the site of a previous cesarean section scar. It was first described in 1978 in a South African journal by Larsen and Solomon, and recently estimated that 1 in 531 women with a cesarean scar will have a cesarean scar pregnancy. Cesarean scar pregnancy has been described in spontaneously conceived pregnancy, as well as after in vitro fertilization and embryo transfer. And if cesarean scar pregnancy continue to the second or third trimesters, there would be a substantial risk of uterine rupture with a catastrophic hemorrhage, with a high risk of hysterectomy causing serious maternal morbidity and loss of future fertility. And if the pregnancy continues within the uterus, the risk of placenta accreta is significantly increased, up to 3 to 5 folds. Cesarean scar pregnancy is classified into two types according to ultrasound scan findings. Type 1 or endogenic is where implantation occurs on the scar and the gestational sac grows towards the cervico-isthmic or uterine cavity. And type 2 or exogenic occurred when the gestational sac is deeply embedded in the scar and the surrounding myometrium and grows toward the bladder. Here the endogenic and here the exogenic. Exogenic and endogenic. What about the clinical presentation? Cesarean scar pregnancy may present as painless vaginal bleeding, abdominal pain, asymptomatic in 37%, severe acute pain with profuse bleeding implies an impending rupture, and finally collapse or hemodynamic instability strongly indicates a rupture cesarean scar pregnancy. Now, what about the diagnosis? Ultrasound is the first line diagnostic tool for cesarean scar pregnancy. There are 5 diagnostic criteria or 5 ultrasound criteria. First, an empty uterine cavity. Second, empty cervical canal. Third, presence of the gestational sac in the anterior part of the uterine isthmus. 4, defect in the myometrial tissue between the bladder and the sac. And finally, triangular gestational sac that fills the niche of the scar. And it classified according to the trophoblast invasion into grade 1 to 4, as you see here. You see here the gestational sac in the cesarean scar and the empty uterine cavity, the empty cervical canal, the implantation in the anterior wall beside the bladder, as you see here. RCOG adopted the same criteria in addition to evidence of prominent circulation on Doppler examination, showing distinct circular peritrophoblastic perfusion surrounding the gestational sac, as you see here. Now, what about the MRI, which can measure the volume of the lesion and evaluate placentation? MRI finding of early cesarean scar pregnancy are similar to ultrasound implantation of gestational sac on the scar, myometrial defect, empty endometrial cavity, and endocervical canal. You see here the gestational sac in the anterior wall of the uterus beside the bladder. Now, what about the diagnostic laparoscopy? The uterus is usually seen normal size or bulky with the cesarean scar pregnancy, arising as a hillock with a salmon red echomotic appearance, bulging the uterine serosa from the previous cesarean section scar behind the bladder. You see here the pregnancy inside the cesarean scar. The histopathology may include lack of basal decidua and myometrium. Cesarean scar pregnancy should be differentiated from spontaneous abortion. The gestational sac should be seen in the cervical canal on ultrasound and on color flow Doppler. The sac should appear avascular, indicated that the sac has been detached from its implantation site. And from cervico-isthmic pregnancy, unlike cesarean scar pregnancy, there would be a layer of healthy myometrium visible between the bladder and the gestational sac on ultrasound. And from trophoblastic tumors, and finally from very low implanted intrauterine pregnancy. Now, what about the management, which include eliminate the embryo, decrease the risk of bleeding, preserve the uterus to maintain further fertility before the gestational sac rupture and hemorrhage. Treatment of cesarean scar pregnancy should be evidence-based and focus on prevention of severe complication and conservation of fertility. Management include expectant, medical and surgical management and other modalities. Medical management includes systemic methotrexate, local injection of embryocytes, combined medical treatment combined with surgical sac aspiration. And surgical management includes uterine curettage, hysteroscopic evacuation, laparoscopic removal, primary open surgical treatment, and hysterectomy. Other modality includes high-intensity focused ultrasound ablation or HIFU, and with or without hysteroscopic suction curettage. Firstly, expectant management, which is not recommended at all. Complications increases as pregnancy progresses. A catastrophic life-threatening maternal hemorrhage. If women want to continue the pregnancy and there's sonographic evidence of the sac growing toward the uterine cavity, and expectant management can be considered at life-threatening risks. Because of the minimum thickness of is unknown. And elective delivery by cesarean section around 28 to 30 weeks with antenatal corticosteroid administration before delivery with the complication rate is high than 53%. Now, what about the medical management? Systemic methotrexate by giving a single dose of 50 milligram per square meter. The secondly, local injection of embryocytes by giving methotrexate or KCL, but methotrexate is the preferred agent. Under ultrasound guidance, methotrexate can be injected locally to the gestational sac. The local injection of embryo of methotrexate or the dose of local injection of methotrexate ranged from 25 to 60 milligram according to multiple studies. With overall cure rate about 70%. Now, combined medical treatment by giving potassium chloride or KCL followed by methotrexate or 50% glucose plus oral methotrexate, etc. And now medical treatment combined with surgical sac aspiration as systemic methotrexate plus transvaginal guided sac aspiration or sac aspiration plus local methotrexate injection, sometimes with mechanical destruction of the heart or of the fetal heart, as you see here, mechanical destruction of the fetal heart, or sometimes injection of methotrexate. Now, what about the surgical management? Firstly, uterine curettage, which is contraindicated in an unruptured cesarean because it might result in rupture of the implanted gestation and massive hemorrhage. The trophoblastic tissue is outside the uterine cavity and thus unreachable by curette. Foley balloon catheter to be inserted for tamponade because of persistent vaginal bleeding. Now, what about hysteroscopic evacuation? The gestational sac is dissected free of uterine wall through natural entrance, and hemostasis can be achieved with electrocoagulation using a wire loop or a roller ball. A balloon catheter can be placed post-operation also. You can do hysteroscopic evacuation by recognize implantation site. Then separate gestational sac from myometrium under direct vision, check bleeding, and perform electrocoagulation. Now, what about laparoscopic removal, which includes some important points? Remove ectopic gestational tissue and repair the defect. Hemorrhage remain a major concern and possible conversion to laparotomy. The cesarean scar pregnancy mass is incised and the pregnancy tissue removed in an endobag. Bleeding can be minimized by local injection of vasopressin. Hemostasis achieved by bipolar diathermy, and the uterine defect closed with endoscopic suturing. And finally, the success rate was very high, around 97%. And there were no reported severe complications. Now, what about primary open surgical treatment, which is mandatory when uterine rupture is confirmed or strongly suspected, and in women who don't respond to conservative medical and facilities for endoscopy are not available. Now, hysterectomy is not advised as primary procedure of treatment, except in cases of intractable hemorrhage due to rupture. It's generally used as a last resort to previous failed procedures or any life-threatening complication or of the procedures. Now, what about the high-intensity focused ultrasound ablation or HIFU with or without hysteroscopy? HIFU ablation could be used to kill cesarean scar pregnancy tissues and destroy small blood vessels around the cesarean scar pregnancy, reducing the blood loss, maybe removing cardiac activity. So thermal effect of HIFU can destroy the pregnancy tissue. Now, what about the future pregnancy? Uneventful future pregnancy have been reported after all modalities of conservative management of cesarean scar pregnancy. The largest study shows a 50% of cases were followed by eventful pregnancy with a mean interval of 13 months. The risk of recurrence has been reported to be around 3 to 5%. Now, follow up by measuring beta SAG weekly until it's undetectable, and by doing transvaginal ultrasound monthly to evaluate the size of retain should be conducted. And finally, in conclusions, ladies and gentlemen, embryo implantation in the region of previous cesarean section scar is a rare but potentially catastrophic complication of a previous cesarean birth. The exponential rise in the incidence during the past 5 to 6 years may be because of rising cesarean section rate worldwide. Ultrasound diagnosis by transvaginal sonography and color flow Doppler, which yields a high diagnostic accuracy. This is expected to emerge as a future gold standard. And finally, there's a plethora of treatment modalities available, but there's no guidelines available regarding the management or follow-up of cesarean scar pregnancy. Thank you so much for your attention.
Professor